Transplant World. One of them is one that Kathy's very familiar with, which is, so you know, for years we've been talking, well, it seems like years, I guess it'll be almost 10 years, we've been using gene expression profiling to determine whether people are having rejection or not, or whether they're at risk for rejection. That became the ALMAP. We helped to develop that. And that's helped us cut down biopsies, helped us to wean immunosuppressive agents. There's now another test which is already being used in another area, and actually it was even written about last week in the editorial page of the Wall Street Journal, so you know that its time has come. And this is called cell-free DNA. So the principle here is that cells break down, and when they break down, they release DNA in the blood. And you can distinguish different DNAs from different people based on some changes in the DNA structure. And there's a fancy name, SNP, or single nucleotide polymorphism, but certain, if you remember the ACTG or the components of DNA from biology, may be different depending upon different individuals. So where is this being used? Well, it's actually being used in women who are pregnant. So in the past, the way to detect birth defects, Down syndrome, and some other ones, was invasive procedures, either amniocentesis or chorionic villus sampling, which ran a risk of, small risk, but a risk of miscarriage or a risk of injury to the fetus or to the mother. And now what's being done is using this approach, you can actually identify DNA from the fetus as well as DNA from the mother. And identifying DNA from the fetus, you can identify whether they have Down syndrome. So this is there's a simple blood test. So how are we using this in the world of transplantation? Within the first 2 weeks after a transplant, there's some injury. Every transplant, heart transplant, there's some injury to the transplanted heart. And because of the actual surgery, the heart being out of the body and then being hooked up. And so there's, you can detect cell-free DNA from the donor as well as the recipient. And then the cell-free DNA levels go way down, unless there's additional damage at some point to the transplanted heart. Rejection, transplant coronary disease, things like that. And so there's actually been, there was a study from Stanford which showed that you could actually detect those using this blood test. So as opposed to the ALMAP, which is essentially a rule-out test where you rule out rejection, this is a rule-in test and also rules in things like transplant coronary disease. And it turns out, Mr. Gleason, that in non-transplant patients as well as transplant patients, you may be able to detect the early presence of cancer because you may be able to detect mutations in the cell-free DNA in certain cells. So that's where cancer fits into that. But I think the next step is we're going to be looking at cell-free DNA and seeing whether we can identify rejection, seeing whether we can identify transplant coronary disease and can intervene earlier. So those are that's one technological advance. Let me tell you about another one, which I saw at the World Transplant Congress, which is not specifically for transplant, but there was a physician who won the Nobel Prize in 2012 for identifying a way of producing stem cells. It's from Japan. And one of the amazing things is he got his own laboratory in 1999, and then 13 years later got the Nobel Prize pretty quick. I don't think anybody's had that kind of record. But what he did was he developed what are called induced pluripotential stem cells. So what he's able to do is take stem cells from the skin, or take, not stem cells, but differentiated cells from the skin, make some changes genetically. He first did this in mice, and then 2 years later was able to replicate it in people. And make these differentiated cells that are easily obtained into stem cells. And then from the stem cells, he can redirect them to any path that he wants. And so he showed, for example, in a rat model of spinal cord injury, that he could regenerate spinal cord and restore motion, normal motion, to the lower extremities of the hind limbs of the rat. And so, and he also showed that he's able to make cardiac myocytes, human cardiac myocytes. So there was a sheet of beating human cardiac cells. Very impressive. So he plans to, initially in Japan, do a bunch of collaborations. The first has been a clinical trial using this for macular degeneration. And there's a plan to, in people with heart failure, to use this for, to reconstruct the heart. Now, what's the advantage? The advantage is that as opposed to stem cells from elsewhere, as opposed to some of the more controversial sources of stem cells like embryonic stem cells, these are stem cells that would come from the patient, be repurposed, or be produced as stem cells, be repurposed as, let's say, heart cells, and you wouldn't reject them because they'd be your own cells. So we are years away from clinical application, but this is something that's very exciting. And then Mr. Gleason, cancer. So Mr. Gleason is interested in cancer because that's one of the two leading causes of death after the first year post-transplant. The other is transplant coronary disease. And while a lot of the most common cancers, breast, colon, lung, are not more common in transplant patients, when they occur, they're more serious. So, you know, there's been a lot of efforts to, first of all, reduce immunosuppression to try to prevent the development of these, or if they develop, to limit their severity. We're trying to modify the American Cancer Society screening algorithm to perhaps be a little bit more vigilant for transplant patients. So, for example, there is no longer a recommendation that people in general get the prostatic surface antigen, men, but we still do that in transplant patients to try to pick up prostate cancer. We are doing cardiac or chest CT scans to look for lung cancer in people who had long smoking histories, usually what I call 30 pack years. So that's the one thing. And then the other thing is the therapies for cancer, and I'm not an oncologist, but I find this to be very cool, which is that you can identify specific mutations in specific types of cancers, and cancers that even look the same histologically, you know, under the microscope, may have totally different mechanisms based on these mutations. And there is a whole series of drugs that are out that inhibit these. Probably the earliest one, the most famous one, is a drug called imatinib or Gleevec, which has been around for about 12 or 13 years to treat chronic myelogenous leukemia.
Is it
So,
Gleevec?
Gleevec, G-L-E-E-V-E-C. So CML is a very common cancer. It's associated with a mutation called the Philadelphia chromosome, which is part of one chromosome is now another. It's very famous, was a person found out at the University of Pennsylvania. When I was a medical student, the professor who discovered this, Peter Knoll, would show it up and everybody would burst into applause. But nobody knew what to do with this. But now this drug called Gleevec, which inhibits a class of proteins called tyrosine kinases. Kinase changes a lot of other proteins. Basically takes these cells, these malignant cells, and makes them go back to being differentiated cells. And there have been a bunch of others. There are at least 2 drugs out that are useful against melanoma, some against lung cancer. And then there's another class of drugs which are work to inhibit PL1. So one of the interesting things about cancers is that they seem to be able to shut the immune system off. The immune system does not respond, which in this case is not a good thing. And what these drugs do is they boost the immune system in response to these cancers. Now, nobody knows what that would do to a transplant patient, and I think we'd need to study that. Fortunately, none of our transplant patients has had type of malignancy. Fortunately, very few have had malignancy, period, but none have had the type of malignancy where these drugs would be used, and they're just becoming available, just been approved by the FDA. So that's cardiologist's take on oncology. Oncology is pretty exciting. So questions?
What are the most common cancers that you see?
Skin cancer.
And beyond that, what's the next one? Much less, of course.
The transplant lymphoproliferative disorders, and then you see the cancers that are most common in the general population, you see breast, colon, lung. Skin cancer is the most common. That's why we try to get people off of as much immunosuppression as we can. You know, a lot of people who were transplanted when they were younger got exposed to sunlight. That does cause damage, which doesn't really go away, and then immunosuppression makes it more likely to reemerge. Yes?
Colonoscopies. Generally, when people go to colonoscopy, you know, you have there's no polyps or whatever's there, and they'll say, "Well, come back in 5 years, come back in 3, whatever." So, for transplant patients, should they be like automatically every 3 years, every 2 years?
They do it every 5 years. I don't think that, but it's a good question. Nobody really knows the answer. We want more colonoscopies.
No, but I wouldn't want any. I wouldn't want to be hanging out there for anything that might happen. So I mean,
Right.
should transplant patients have more often colonoscopies versus the
Yeah, I think the
regular
recommendation is every 5 as opposed to every 10 years.
population?
Again, that goes back to being better educated from a transplant standpoint, because your doctor would say, or somebody doing a colonoscopy, see you in 10 years.
Right.
You would say, nah, I need to do it in 5.
Right.
What other types of symptoms should we be looking out for? Skin, take that aside. That's well covered, a lot of evidence out there, a lot of stuff educating. But beyond that, what other kinds of things, colonoscopy being one, should a transplant patient be looking for to be aware, catch
Well, you know,
things
anything
early?
that's different, you know, if you're short of breath, if you're coughing, if you're fatigued, night sweats, new lymph nodes, bleeding in the urine, bleeding in the bowel, coughing up. Any of the standard, I mean, the symptoms are similar to the symptoms of cancer in non-transplant patients. Weight loss.
And certainly if you have a slight fever or something like that,
Well, that should be checked out anyway.
we-
It's probably not going to be malignancy. It's probably going to be infectious, but
right.
it's, you know, it should be checked out.
And that's something you want us to call you with.
Above 99.5, yes.
That's right.
Yes.
And then the new protocol wasn't it 101 or 100.5 before?
Yeah, I think we've scaled it down a little bit, but at least talk to, you know, not necessarily come in, but 100.5 and above, we usually have you come in.
Come on down.
Correct. All right, well, listen, thank you very much.
Thank you.
Thank you very much.
Thank you, Howard.
All right.
Thank you.
Have some lunch for us.
I'll come back.